Καλώς ορίσατε σε ένα ακόμα συναρπαστικό επεισόδιο του Focus Fitness Radio. Σήμερα έχουμε την τιμή να φιλοξενούμε έναν από τους κορυφαίους επιστήμονες στον τομέα της βιομηχανικής Σπονδυλικής Στήλης, τον Dr. Stuart McGill. Σήμερα θα είναι ένα ξεχωριστό επεισόδιο, διότι κατά τη διάρκεια του podcast μας θα γίνουν περίπου 7 διαλύματα, στα οποία θα αναλύουμε πράγματα. Θα βάζουμε και το δικό μας το κομμάτι, το πώς ερμηνεύουμε από την εμπειρία μας όλα αυτά τα χρόνια τα πράγματα στα οποία εκφράζεται, απορίες οι οποίες μας δημιουργήθηκαν και απορίες που μπορούν να δημιουργηθούν και σε εσάς από τα μηνύματα τα οποία λάβαμε. Ο Dr. McGill, μια καριέρα που εκτείνεται σε περίπου 4 δεκαετίες έρευνας και κλινικής πρακτικής, έχει βοηθήσει αμέτρητους ανθρώπους, από καθημερινούς ασθενείς μέχρι και παγκόσμιους πρωταθλητές, τόσο να ξεπεράσουν τα προβλήματα πόνου, όσο να βελτιώσουν την απόδοσή τους. Σήμερα λοιπόν θα εξερευνήσουμε τις γνώσεις του για τη σπονδυλική στήλη, τη σωστή κίνηση, την απόδοση, ενώ θα μας προσφέρει μια εκπληκτική παρουσίαση, η οποία έγινε στην Αμερική για πολύ λίγο κόσμο και μας έκανε τη χαρά να τη μοιραστεί μαζί μας. Ετοιμαστείτε για μια συζήτηση γεμάτη σοφία, έμπνευση και πρακτική καθοδήγηση.
Hello, Dr. McGill. Welcome to Focus Fitness Radio. So nice to see you. It's been a while. I want to thank you personally for being there for me. You've been a mentor. You've been always answering questions, guiding me. And to be honest, I consider you. And thank you from a scientist kind of doing all the work and all the sacrifices and making our life a bit easier in the path of not chasing pain, but trying to treat people and give them back what they've lost.
Thank you. Good morning, or I guess it's good afternoon to you in Thessalonia.
Yeah,
no,
Thessaloniki. Yeah, exactly.
Right. Well, good day, whatever time it is for you there, Rocco. And likewise, I've enjoyed our discussions, our friendship, and our relationship over the years very, very much.
I'm still thinking about those days in Athens.
Yeah, well, it's my daughter's birthday, and you may recall, I don't know how many years ago it would be now, 8, maybe 9,
8
10,
years, yeah.
When she
Yeah.
and some Greek philosophy inscribed on the top. So again, you carry through life these experiences, and that is one that I will never forget, and she will never forget. Fabulous time. But only a true Athenian would know where that place was, because there were no tourists.
Nope. It was proper Greek restaurant with no proper, locals. Yeah. Hopefully we can do that again soon.
It was memorable. Fantastic.
Dr. McGill, I'm going to cut through the chase. You mentioned that back pain is often not chronic, but consists of many acute episodes. And you've been misunderstood many times, but can you please elaborate on what this means for patients and practitioners, please?
Acute versus chronic low back pain. I think most people define the two differently based on timeline. So if someone has back pain lasting longer than a statute of time, I've heard 3 months is often used by, say, the insurance industry, then the pain goes from acute to chronic, and then the chance of it resolving greatly decreases. And my comments are based on that's not consistent with our assessment result with patients. We think of chronic pain as involving the neural system. Something becomes corrupted by pain or injury, or at least changed, so that the pain doesn't really match the stimulus in the moment. And we detect that with our assessment. There's central sensitization. But what the assessment does show, when we create the person's pain with an applied load or a motion or a posture or a specific activity, and we modify the activity or the posture, we get immediate change in the pain. In other words, it wasn't due to a changed neural system. It was a pure one-on-one offense of something that's causing pain. Let's use an example of, say, an open fissured disc bulge that grows when you squeeze it and bend it away from the bulge. If you were to decompress that disc, and one method that we've found, and it would be a very McKenzie posture direction type of approach, bend the disc the other way and add a little bit of, have them prone lay, shake their legs a little bit, and they'll say, oh, that's taking my pain away. And then we might measure the offense immediately, and it is now reduced. In other words, we didn't change neurology. We changed the mechanics of the offense. In that particular person, they may have had that for a year, classified as chronic back pain and a poor risk to rehabilitate. And yet immediately we can change the result. And we documented that in some work published in Spine, you know, the biggest orthopedic journal in our area that exists. So our assessment showed they didn't have chronic pain. Their pain was caused by, unbeknownst to them, many acute insults of the pain mechanism throughout the day that kept them sensitized. And when they learned to move and not to repeat that, their pain greatly decreased. They were having actually many acute episodes all day long. You know, the best analogy I could give would be of stubbing your toe. If you stub your toe one day, all right, well, it hurts a little bit. But if you do it again the next day, I've heard people say biting your lip would be another example. You keep stubbing your toe until finally on the third day you touch your toe and you scream. It's been sensitive. Now, what do? Do you just say, oh, well, you've got a chronic toe? No, stop stubbing your toe and it'll go away. It'll desensitize. That's a very simple example. But anyway, what our assessment shows is that most people, and I'm not exaggerating when I say most, meaning much more than 50%, when you remove the mini acute insults, the pain decreases, and that was what they had. They didn't have chronic pain. Now, just to finish off that whole essay, shall we say, there are those who have changes to their perception of pain mechanism and the way that their pain sensitivity is unwound is quite different. But it's quite rare when we get a true chronic low back pain patient.
It's really important.
Εξαιρετική πάσα πάνω στο κομμάτι το οποίο μιλάει ο Dr. McGill. Έλεγε η διδασκαλία Zen, λέει όταν ο μαθητής είναι έτοιμος, ο δάσκαλος εμφανίζεται. 17-18 Φεβρουαρίου, θυμάμαι του 18 Γιάννη, ήταν 30 οι μαθητές, αν θυμάμαι καλά, ήταν παρόν στο σεμινάριο του McGill, όπου πέρασε, όσοι ήταν παρόν θα θυμούνται έτσι με μεγάλη ακρίβεια και πράγματα τα οποία πολλοί κόσμος είχε παρεξηγήσει και τα παρεξηγεί γιατί αφενός και δεν έχει διαβάσει τη βιβλιογραφία του, δεν είναι παρόν στα σεμινάρια, οπότε ξέρεις, παίρνει κομμάτια από εκεί που θέλει για να ταιριάζουν, εν πάση περιπτώσει, στο εγώ του, στη φοβία του να πει δεν ξέρω. Και μου έκανε φοβερή εντύπωση σε ένα σεμινάριο, με κάλεσε μετά από περίπου 2 εβδομάδες να βοηθήσω κατόπιν να είμαι παρόν, εν πάση, σε ένα σεμινάριο στο Σερβία. Δεν θυμάμαι τώρα που ήταν ακριβώς, θα θυμηθώ. Και είχαμε 120 άτομα τα οποία ήταν εκεί και αν θυμάμαι καλά, Γιάννη, ήταν από τα 30 άτομα που ήταν στο σεμινάριο στην Ελλάδα, ήταν ή 6 ή 7 από το εξωτερικό. Εντάξει, άνω τελεία. Στο τελείωμα το οποίο της ερώτησης του, γιατί πολλές φορές μπαίνουμε στη διαδικασία της διάγνωσης τύπου copy-paste, έλα μωρέ, όμικρον 5Ι1 είναι, ξέρεις, έλα μωρέ, αυτό είναι. Η ερώτηση η οποία ακολουθεί είναι ότι, και αυτό που λέει πολλές φορές, ότι το σύμπτωμα οδηγείται από 100 διαφορετικές οδούς. Και αυτό που λέμε πολλές φορές, if you're not, λέει, assessing, you're guessing. Έτσι, αν δεν γίνει μια σωστή αξιολόγηση εν το βάθη για να δεις από πού προέρχεται αυτός ο πόνος. Και απλά το ρώτησα, το οποίο με ενδιαφέρει και εμένα προσωπικά, πέρα από τις σκηνές που βλέπει σύνηθες, σε πάση περιπτώσει, οδούς για να φτάσουμε στο σύμπτωμα, ποιες είναι οι πιο παραμελημένες? Για πάμε να δούμε τι είπε.
It's really important what you said, assessing and trying to figure out how you're going to find that out, like some specific stress test that you just found, or if you have a tool like our friend dynamic discs, and as you said, prior to showing, especially to the patient that's going through all this agonizing pain, that you assessed it, you found what triggers it, and then you took it away. And that's really important because there's so many generalizations out there of what people can do, and they're not too in-depth for the specific individual. And that's actually what's causing their issue. And besides what the insurance company they say about chronic pain, and that makes a massive difference. I've been to your workshops and seminars numerous times. I wasn't taught all that at uni, if that makes sense. Dr. McGill, you've stated more than once that back pain is a symptom with 100 different pathways leading to it. Can you discuss just briefly some of the most common and overlooked pathways, please?
Yeah, it comes right back to the very detailed assessment approach. Once again, to repeat, back pain, it's only a symptom. And, you know, I use this analogy quite a bit. Let's take pain in another region of the body. Let's say leg pain. Someone comes to you with leg pain and they say, Dr. Venizelos, could you give me an exercise for my pain? Now, what clinician would say, oh, well, go do squats, and you haven't determined yet whether they've got torn knee ligaments, a patella that isn't tracking appropriately and is generating pain, or muscle soreness, or a nerve pathology, or a fracture, or what? Of course, you've got to determine the mechanism of that leg pain. In the same way, I don't know why, but in many people, they will say, if you have the symptom of back pain, then you will, I'm going to give you a procedure that I'm trained in and that I can bill for. And this is what you're going to get. So it's a matter of dumb luck. But a thorough assessment that's unbiased. You know, I'm completely agnostic as to what intervention I'm going to use, but the thorough testing will lead us and inform what the intervention will. So in terms of, you use the word 100 different pathways, there's probably more than that with all the combinations of mechanisms. But let's just take the most common, which will involve disc dysfunction in some form. So let's say the disc has been overloaded in compression and there's a small little end plate. Imagine letting a little air out of your car tire. It flattens, it bulges on the road, and now the car drives a little bit differently. It's a little bit more sloppy. In other words, the tire, when it was inflated, gave a stiffness that gave control. Now, the body at every single joint uses stiffness as the control, either through contracting and co-contracting muscle. When a muscle contracts, it creates force and stiffness, and it's the stiffness that does the control, while the force does the eventual moving. So now there's a little bit of height loss. But the cofactor with that is, by definition, there's now a little bit of micro movement at the joint, akin to letting a little bit of air out of the car tire. If a person comes to you and says, you know, my pain, when I lay on my left side, I get an ache in the right side of my low back and it flares into my glute. So they're laying on their side, they got a little micro movement going this way. And then they say, I lay on my other side and the pain changes. I get another kind of ache. It might shift sides or it might go down the opposite leg or whatnot. If the pain migrates, there's something mechanical that...
Ακούγοντας αυτήν την ιστορία και αρκετές προσωπικές ιστορίες του Dr. McGill, μπορώ να πω ότι η συνεργασία μας τελευταία 8 χρόνια με έχει κάνει πέρα από καλύτερο άνθρωπο και θεωρώ καλύτερο θεραπευτή. είναι το κομμάτι το οποίο δύο κουβέντες θα κρατήσω από όλο αυτό, το οποίο το λέει και το συζητάμε και λίγο πιο μετά. Του λέω πώς φτάνει στο κομμάτι του να μπει στη διαδικασία της, ας πούμε, διάγνωση, ας χρησιμοποιήσουμε αυτή τη λέξη. Μου λέει παίζω jazz. Όποιος ακούει jazz μπορεί να καταλάβει ότι μπαίνει ένας άνθρωπος σε μια διαδικασία που ακολουθεί πολλές εργαλειοθήκες όπως έχει, και θα χρησιμοποιήσω και μια τάκα ενός άλλου μέντορα του Εμμανουήλ Φράντσις, Dr. Εμμανουήλ Φράντσις, ο οποίος γυρνάει και λέει ότι αν κάποιος προσπαθεί να σου πλασάρει μια συγκεκριμένη μέθοδο, κάτι θέλει να σου πουλήσει. Το ίδιο λέει και ο Στούαρτ λίγος πολύ. Η διαδικασία του ιστορικού, το οποίο μπαίνουμε στη διαδικασία και το ξεχνάμε πάρα πολύ. Κάποιος τους ξενίζει, κάποιοι το θεωρούν κουραστικό, κάποιοι το χρησιμοποιούν καθόλου. Κάποιος σου λέει πονάει μέση μου, έλα ξάπλωσε, σε είδα πως μπήκες μέσα. Όπως βλέπουμε τώρα αυτόν τον άνθρωπο που συζητάει για την πανδημία, ένας άνθρωπος ο οποίος ασχολούνταν πολύ στον υπολογιστή, αναγκάστηκε να καθίσει πολύ περισσότερο. Και κυρίως για όλους αυτούς εκεί έξω οι οποίοι λένε ότι η στάση και γενικά η καθιστική ζωή και η κακή στάση για παραταμένο χρόνο δεν παίζει κανένα ρόλο. Εδώ θα πούμε ο Σπίνα λέει ότι η χειρότερη στάση είναι αυτή που κρατάς για πάρα πολύ μεγάλο χρονικό διάστημα. Ο καθένας έχει την αλήθεια του. Απλά αυτός ο οποίος θέλει να παραμείνει, να το πούμε έτσι, ταπεινός και έχει ασχοληθεί με ανθρώπους στον πόνο, ίσως καταλάβει κάποια πράγματα παραπάνω. Αυτός που ίσως σηκώσει το φρυδάκι του και πει τι λένε τώρα αυτοί εκεί, ίσως να κατέβει λίγο, να εξισορροπηθεί με την πραγματικότητα πώς είναι να υπάρχει ένας άνθρωπος στον πόνο και να μην χρησιμοποιεί τόσο βαρύδουπες εκφράσεις ότι έλα μωρέ, το να είσαι σε αυτή τη στάση, σε εντός αγωγικών λάθος στάση, να το πούμε έτσι, για μεγάλο χρονικό διάστημα, δεν επηρεάζει. Καλύτερα να το ξανασκεφτεί.
You've got joint laxity. So are you going to give them more mobilizations when they are already overly lax? Or they might say, now that when I go into extension, I get a dull ache right in the center of my back at the bottom. Yeah, the micro movements are now overloading the posterior elements in extension. And again, you keep following these hypotheses up with very thorough assessments. So that would be a very common pathway, shall we say. Let's take another one of the last patient I saw yesterday. A very, very deconditioned fellow, very nice man. In the pandemic, he stopped exercising. He was a computer programmer. And eventually, because he felt constrained, he would sleep in his bed, and his desk and office was in his bedroom. And so
Incredible.
He has been going to a massage therapist, who I know, a very good one, and now the massage is hurting him. We talked about micro movements in the last example, but the massage is stirring up a hornet's nest, insulting mini-acutely the micro movements, replicating his symptoms. In other words, it's no longer helpful. It used to be, but it's no longer now. And so the massage therapist sent him to us. We detected this in the assessment. But my point there is talk about the biopsychosocial milieu around his life. It was a worldwide pandemic that is very much part of this whole story. It's his personality that he then reacted to that social stressor by staying in his bed. You see, it's a house of cards. And now what is the impediment to getting him better? He is so fearful of movement because he doesn't know how. And when he moves, he gets these movement catches or triggers from the micro movements. Yeah. And he's very fearful, extremely fearful. Well, again, we've got the full spectrum now of the biopsychosocial approach. The first thing we did was to understand the mechanism of these movement catches and why when he sits and slouches, it creates a very familiar subtype of pain, not the movement catch, and then give him a strategy to mitigate it, sit with a lumbar support. do some exercises now. You've got to start moving. And I gave him the bird dog. And he said, but my massage therapist showed me the bird dog and it hurts me. I said, really? Show me the bird dog. And he didn't set up the quadruped base. He didn't engage any stabilizing muscles that were absolutely necessary to arrest the micro movements. And his shoulder was... And then I said, he reached up and his shoulder started to ache. And I said, what I want you to do is grab the ground and pull the ground. Obviously, you can't move, but you're engaging by pulling your hands towards your knees, the lower traps, the serratus anterior, more cues, push the earth away and try and pull your hands to your knees. Bird dog, zero pain. It was an understanding of, because most people have to fly here. They travel a long distance. I don't see local people. And he said, you know what? I don't have any pain. Now, that sounds like a very boastful thing to say, but, you know, it's not unusual.
Stu, if I may, I've seen that happening in your lab. I've seen it happening in your seminar. So it's not boast.
I'm sure you see it in your own clinic.
And I said, yeah, of course, yeah.
You know, with all the impediments to his recovery, the first order of business was to give him permission to move, and then to move and stimulate adaptation in a way that is tolerable and relieving. It made him feel better. In other words, the exercise him more than it took away. It takes a fair amount of expertise to do that. So when I hear people, oh, do a bird dog. Oh, I tried the bird dog. It didn't work. It hurt me. Oh, really? Well, where'd you learn how to do a bird dog? Oh, I saw a video on YouTube. And then, you know, the person just slaughters it and has no idea of the ability to guide a person through all this with a bit of expertise.
It's like giving a child a knife. If you don't teach someone how to use the knife, they can either cut their finger or cut a steak. Usually what you see, especially nowadays with all those, you know, with the social media, and these are the best exercises for your lower back, without assessing and without not actually knowing the exercise and how to coach it for the individual. It's insulting. But to be honest, now that you were saying about...
This is the funny thing, you know, Rocco. I wish I could retire. I as you know, we don't advertise. We don't... We're not out posting on social media or whatnot. There's nowhere, anywhere that says to get an appointment with McGill, you know, sign up here. Where's my office? I mean, you got to work like the devil to find out, you know, where the office is and where the headquarters of BackFit Pro is and where all our providers are around the world. But I still wake up every day to sometimes hundreds in a single day of requests from around the world. Would you entertain the idea of seeing us? And, you know, I can't. It's not possible. But I wish I could retire tomorrow, but they are, how shall I word this? Many of them are kept.
Τώρα ξεκινάει το zoom της υπόθεσης. Μας έκανε μια έτσι εκπληκτική παρουσίαση η οποία ακολουθεί και για όσους εσάς είστε στο Spotify μπορεί να τη δει την παρουσίαση και εκεί, όπου ουσιαστικά τι γίνεται. Ακολουθεί μια ερώτηση για το πόσο εν πάση περιπτώσει μπορεί ο δίσκος να προσαρμοστεί, πόσο ο δίσκος μπορεί να επανέλθει, όπως έχουμε ακούσει πολλές φορές από κάποιους να λένε ότι επανέρχεται στην πρώιμη κατάσταση. Και τελικά αυτό που θέλουμε να δούμε, τι είναι αυτός ο δίσκος, έτσι, πώς λειτουργεί, με νέες έρευνες, γιατί πολλοί θέλουν να κρατάνε, όπως είπα και προηγουμένως, πράγματα πεπαλαιωμένα, πράγματα τα οποία ενισχύουν το εγώ τους. Χρησιμοποίησε έρευνες άλλων πολύ υψηλά ιστάμενων επιστημόνων, τελευταίες έρευνες, γιατί έχουμε και αυτό τώρα, έχουμε συζητήσει πολλές φορές με το Γιάννη, το κομμάτι αυτό, ότι ξέρεις, αν δεν είναι του 24, του 25, ό,τι προηγούμενο έχει γίνει, του 20 δεν μετράει. Οπότε, δόξα τω Θεώ, μπήκε στη διαδικασία και έβαλε τελευταίες, οι οποίες όντως έχουν γίνει και από αυτόν σε πιο πρώιμα στάδια. Στο ίδιο αποτέλεσμα φτάνει, αλλά ειλικρινά χάρηκα και έμαθα πάρα πολλά από αυτήν την παρουσίαση και ελπίζω να μάθετε κι εσείς και αν έχετε οποιασδήποτε ερωτήσεις, με χαρά να τις βάλετε από κάτω και να τις στείλουμε στον ίδιο να μας απαντήσει.
I know what you mean. I know who you are, and that's why you cannot retire. My mind started going, 100 ways now because you said about those micro movements and those shear forces into the pain mitigation and all that. And the question is, can the disc adapt?
Yes, but it's a very qualified. And then I would also answer it no with a lot of qualifications. I did give a lecture at a conference earlier in the year where I was asked to speak on exactly the same question. On my computer, I have a little slideshow. It's about 20 slides.
Yes, please.
I could work through that in about 10 minutes.
Yes, please. I would love that.
Again, go through the nuances of why it's a very qualified yes or it could be a no. Just let me click on a couple of things here, Rocco. So
Thank you. I really appreciate
I understand now this format, I have to click share, correct?
Yes.
Okay. And I'm going to share my screen. Okay. And now I'm going to, can you see that?
No, I cannot see it. Yeah, no worries.
I'm going to share my entire screen. I'm going to share. Oh, there we are. And now I can hit share. And now
perfect.
I can. Now, can you see that?
Yes, I can. Yeah.
Okay, let me just go to that mode. Can you see that?
Yes, potential for
okay,
disc
and you can see
yes.
my arrow moving to guide your eye.
Yes, yes, sir.
Okay, so the question is, can you adapt? I started to review the literature as I've been retired from the university a few years now, so I thought I better get. And then I discovered that Rafili and his colleagues had already done a good review on this question. So just to summarize Rafili's work, which was really based on cells in the intervertebral, he found an anabolic response or a positive response to load in the nucleus, but it was only with loads up to those experienced, and he only found anabolic positive adaptive responses in non-degenerated nucleuses. So if the nucleus or the disc was already changed through micro-injury, it didn't positively adapt. In summary, the load has to be modest and it has to be applied to a non-degenerative, say a virgin tissue. So remember that, because now if the person is young, they have a chance to adapt more mobility and more load-bearing ability if the loads are modest. But what our research has shown over the last, I worked at it for 32 years, you can adapt the collagen matrix of the disc to become more mobile at the sacrifice of bearing more load. So if you really want to be mobile, you'll have to back off on some of the heavy load training. If you want to really bear heavy load, you're adapting not only the collagen matrix and the nucleus, but also the bone, particularly the vertebral bone and the end plates, to bear heavy load. But at the price, you become stiffer and you lose mobility. So most people want to be somewhere. Sorry?
Always a trade-off.
There's always a trade-off. That's exactly right. Well, let's put some context to this. There's a person flexing and touching their toes, and some people think, oh, well, McGill's going to be upset with this. Let me be clear. I couldn't care. If the person has no pain and no injury history, I have no issue with this whatsoever. However, if the person comes and sees us with pain now, we have a context and a specificity. If we do a seated loaded compression test, so the person flexes, pulls up on the chair, and this very specifically replicates the precise description of their low back pain, and it replicates the left smaller toes going numb. I now am very concerned about them doing that in their life. That constitutes a mini acute insult of their pain management. So now let's go to the base. They form the category of a adaptable composite fabric. Adaptable only before they become degenerated or micro-injured, shall we say. So we've got a pressurized nuclear gel, which is considered as a non-compressible hydraulic fluid, surrounded by concentric rings of collagen fibers, where each ring, the collagen, runs a different way. So you can see if you twist or bend, there are delamination stresses, just like in my shirt. For example, if I was to take a small section of my shirt, which is a fabric, bend it back and forth over and over and over again, it will create a hole through fiber delamination in my shirt. Let's look at the base constituents of the annulus. It has type 1 collagen in a disc. It's about 80% type 1, which gives strength and stiffness to the disc, which is a highly efficient design. The stiffness means as you bend, when you get to the end range, it's supported by the collagen fibers. You don't need muscle, in other words. It's highly efficient. It allows us to be more slender. It allows us to run and that kind of thing. Otherwise, we'd be built like a whale with enormous musculature if we didn't have stiff collagen. About 20% is type 2 collagen, which gives the elastic behavior and allows the collagen strands to elongate under tensile stress. But there's collagen types 3 through 10, which bind these collagen fibers together to stop them from delaminating. Now, we'll just call types 3 through 10 collectively type X. The ability to bear load and adapt is probably more governed by the genetics and the training of your type X binding collagen. Some people are born with collagen so that they can do repeated bending without delamination. They're world champion rowers and scullers would be one example. And the next person just couldn't tolerate repeated bending. That's based on, life isn't fair. Hopefully they're doing something else. And then the training, if you want to be Dave Tate, don't move your spine around, don't do sit-ups. Train the collagen to become stiffer in the type X. But if you want to be mobile, fine, I have no problem with that, but I would be a little bit careful in loading the spine heavy. Now, there are those who've been blessed by the hand of God, do have the collagen that will allow a little bit more of both of those simultaneously. Well, I was fascinated by people's comments on the ability to adapt collagen and they would often cite Professor Jill Cook's work in Australia, which is very good work. It's on the Achilles tendon, and her work has shown that if you they don't have much type X in a tendon, and particularly in the Achilles. So let's look at the disc now, which takes entirely different stresses in that the applied stress is not in line with the collagen fibers, and how could they be? In every concentric ring on the annulus, the fibers run in a different direction. In this blue outer layer, they run 30 degrees in this way. The next layer, they run the other way. And the next layer, they run back and forth. In other words, it's a cross-ply architecture. So my colleagues, Noguchi and Professor Jack Callahan, one of my colleagues at the University of Waterloo, who ran one of the spine laboratories, would document collagen in the disc prior. You can see the differential stresses in the collagen fibers with bending, for example. So dye the nucleus a chromium blue, bend the spine, and in this particular case, this is the posterior aspect of the disc. It was loaded and then bent in flexion over and over again, and you see the delamination stresses going posteriorly and around the periphery, and that will eventually turn into a disc bulge. That's a limacon-shaped disc, an ovoid-shaped. If it was limacon, there'd be more of a bigger radius here and here. Those actually herniate faster with repeated bending. It's explained in that the radial distance is greater there. And they don't they do respond to McKenzie directional therapy much more than an ovoid spine, which is kind of interesting. But then when we look at the twisting, which would delaminate the concentric cycles from one another because of the interlaminar stresses. We document the collagen, the nucleus migrating up between layers. So here we've surgically, layer by layer, peel off the layers of the annulus, and on a radiology image, like an MR, for example, radiologists would report that as an interlaminar rent or perhaps a disc tear. But that comes from twisting when you understand the stresses. Yeah. So, I then look at the literature. Discs don't heal once they've been damaged. You lose the ability to adapt them, and you fall now into the category of you have to manage them. Degenerative process causes the nucleus to become fibrocartilaginous. It stiffens up. You lose compliance. And in other words, you cannot treat it like you did when you were 16. Now, I'm not going to say that people should be very despondent in that, because as a proof of principle, as you know, we've had people with very damaged discs, and we've managed them back and trained them back to set the highest load-bearing records in history, the highest squat in human history. We've had some of the fastest athletes competing at the Olympics and professional sport. So it was through management of understanding that we're not adapting, but we're managing a. So, as I said, we can't turn you back into 16 and give you carte blanche again. I've got a couple more points, if you will allow me, Rocco. People think, repeated flexion is the big bogeyman, but it's so much more than that. Let me show you statistically now, probably the most common pathway leading to a disc bulge, but it doesn't start with a disc story. It starts with a bone fracture story. So many people epidemiologically will report, my back troubles that eventually ended up with a disc bulge started with a heavy deadlift. And now I'm not saying deadlifts are bad. I'm just saying they did a deadlift that exceeded their current tolerance. So we would take an animal spine again, because I can't find a human that would allow us to fracture their spine. We put it into a high-resolution CT scanner, and you see that is their virgin disc. Then we take it out and we load it with a simulated deadlift load, double their body weight, and you see at a micro level the broken trabecular bone underneath the end plate. Collagen fibers join in and fuse into the end plate through the Sharpie's fibers. But now that the anchors have been broken, the collagen fibers, when they're stressed with more compression and bending, break away and pull little bits of cartilage off. And through the disc herniation process, if they now continued loaded flexion, there's an open fissure that goes through the delaminated collagen and then forms a disc bulge. So there's a lot of things that happen with that initial compressive damage, but one of them is the loss of connectivity of the collagen fiber. Well, I'll just gloss over some of this other evidence, and now let me talk about the disc bulge. Here is just a beautiful example of a to the nucleus herniating vertically through the end plate fracture, residing in the bone and setting off an inflammatory response. It causes a central bone ache. But now they then repeatedly bend, doing deep squats, as this particular athlete was doing with his trainer, and then the collagen fibers, losing their connectivity, delaminate, and the hydraulic stress in the annulus is forcing in the nucleus, is forcing the nuclear gel to carry the broken bits of bone out into the disc herniation. And then this is the surgical report where the harvested nuclear material was then assessed, and they found end plate bits, meaning that it started with a compressive, excessive end plate fracture. Well, now let's go to the Issels Prize of 2013. Issels, the International Society for Study of the Lumbar Spine, is the top orthopedic society for lumbar spine in the world. These are very good groups of clinicians and scientists. Rajaskarian and his colleagues took 181 subjects, and they analyzed the nuclear material that was harvested, and more than half, meaning 65% of those disc herniations contained, in other words, their disc bulge started with an end plate fracture. And you know from your clinic, when you follow them up, many people will say, I started with a heavy compression. Either I slipped and fell, landed on my behind and pelvis, I pile drived my back and created a fracture that way, or it might have been a cumulative weight room genesis. Anyway, once that starts, and now when they add loaded flexion, it has even a more deleterious effect, because they will not adapt that disc by adding more loaded flexion. Well, I'm just going to skip ahead to the last little bit and two more bits of evidence. This is more recent from Peng Fei's group in China. I think they've done an excellent job in explaining the biochemistry and the immunoresponse of simultaneous and rapid reabsorption of a disc bulge, which we know happens. And curiously, the bigger the disc bulge, the faster it can resorb. Some of the smaller ones are a little bit pesky. Well, why is all of that? And you will recall my explanation of the end plate fracture. If there is an end plate fracture, and if there is a modic change, the to better manage our disc bulge patients. And the final bit of evidence, you know, one of the best disc biomechanists over the years has been Mike Adams and his partner Trish Dolan. I've known them for the better part of 40 years. They're just a fabulous, well, people, humans, but also scientists. And towards the end of their careers, they're both retired now, like me, but they really converged on this idea of distinct phenotypes that we're born with. In other words, the end plate driven disc degeneration, the kind that starts with end plate fracture, tends to be more in families. It's inherited, and load matters less. And then there's the other phenotype where it's an annulus driven. That is mechanically driven. It doesn't matter who your parents were. Just to give a visual on that, these type of end plate fractures and the strength of the bone and whatnot seems to run in families, whereas the intact, healthy end plates, but just a disc bulge caused by repeated loaded flexion that's excessive. It's driven by mechanics. Anyway, I can go on as I did for an hour in the lecture, but at the end of the day, we can say that disc injury, it's a deviated posture, load kind of injury. It can be from mini acute exposures or a major one like a slip and a fall. But basically, a wise clinician savvy with all of this doesn't talk about low back pain and what to do about it. They perform an assessment that reveals all of these mechanisms. It's a very comprehensive assessment. It requires a lot of skill to perform the assessment. And they are able to change the life of that person when many of their colleagues have failed. I'm not going to apologize. That's why I say the things that I do, and my interpretation of where we currently reside. And in the grand scheme, I haven't changed my opinions very much. Our science has been quite consistent through this whole process. And as we blend the science of very good scientists who take different perspectives.
No, that was, I wish I was there for presentation, because this was a lot of food for thought, to be honest, and especially for the last part that you talk about the immunology. I've been to your seminars, and you always said about bone growth, and you always put the biochemistry and the biology of growth and actually how to manage any kind of problems that come with disc degeneration. But doesn't it make sense now, like you lose water when in a disc bulge, which means you're going to lose all the macromolecules like proteoglycans that they are in the disc. So then how would you be able to repair if you don't follow the correct method, let's say, or if you don't keep away from repeating the same pattern that makes more water, more macromolecules come out of your disc? Does that make sense?
I think I know what you're getting at, but my answer, it's always the same. A thorough assessment. And most people have no idea of what that means. But a thorough assessment that starts with an extensive interview. So I really understand this person's life, why they've failed in the past, what are the impediments that we must remove to change the failure history into a successful one. One that understands their pain pattern, the demands of their life, etc. And then do a very thorough probing through provocative challenge of the pain to provoke it, to really understand it, and then find ways to mitigate that. If it is mechanical, through changing the way they perform an activity, perhaps posture and movement, and distributes stress. And the idea is to migrate it from one tissue to another, one that's robust away from the one that's not robust at the moment. Address their specific concerns. So, I wrote a whole book with Brian Carroll on this, so that's documented. So that's a nice example. He had a massive fracture in the sacral plateau. If we couldn't seal that end plate fracture, there was no way he could seal the disc and start to create a biochemical environment for the disc to become viable again. So we started that whole process with, Brian, use spine hygiene, but we're going to load your spine because the first thing we have to do is build bone. And we went into a bone callousing routine, and that lasted months. So, the next person comes in and they've got a recent stress fracture that just turned into a full fracture of the neural arch. They could go to a person and say, oh, well, we need to take your spine through the ring. You don't want to lose that. That is exactly what's going to cause the fracture to come apart, and the chance of a bony union forming becomes compromised. Instead, we will figure out what is required to get those bones to approximate, and then by restricting the movement, try and get first a gristling to take place that will then form a bone callus and a full heavy ossification. And we've done that many times with gymnasts. Every Olympic cycle is so interesting. We will get athletes who are throwers. And interestingly, on their team, 4 people have stress fractures. Well, the next group of throwers have 0 stress fractures. Guess who's causing the stress fractures? The strength and conditioning coach of that particular team. It's not the sport. So, we study these clusters and why. So there would be an example of don't move it and let the bony callus form. The next one might be, yes, we've got to try and do all we can for simultaneous resorption. And with them, we might just say, do a little bit of a tummy lay, have someone pull on your legs, add a little bit of motion. We discovered in the lab that's the fastest way to get, if I can use the word simple, disc bulge, which is one where the end plates are intact. There's no modic change. It's just a straight fissure. And then can we lock it in place by not bending forward? And then over time, maybe this person is a triathlete and to becoming a champion at the national level for their country. There's 3 examples where knowledge of the pathway of injury coupled with knowing the right tools to encourage those, and you're managing them, but you're not curing them. Neither of those 3 examples will be 16 again, but knowing what they can and cannot do. Here I'm where I am. I'm in the BackFit Pro headquarters, and I'm just looking over at, if I can use my finger here, there's the belt squat machine. So we would have them not flat, but
them.
very appropriate for that particular person.
Είναι εκπληκτικό το κομμάτι, το πώς έγινε αυτή η παρουσίαση. Δεν ξέρω πόσες φορές την έχουμε δει με τον Γιάννη και κρατάμε σημειώσεις ακόμα. Γιατί ο σκοπός γενικά όλων των επεισοδίων είναι να δημιουργούνται ερωτήματα. Και όλο αυτό ξεκίνησε κυρίως για εμάς. Αν θυμάσαι καλά, Γιάννη, μπήκαμε δηλαδή στη διαδικασία αυτή να ερχόμαστε με ανθρώπους προφανώς με μεγαλύτερη εμπειρία, καλύτερους από εμάς, και για όσους παίζουν σπορ θα καταλάβουν ότι για να μπορέσει να γίνεις καλύτερο πρέπει να παίζεις με ένα καλύτερο. Αν παίζεις συνέχεια με έναν ο οποίος είναι λιγότερο καλός από σένα, θα νομίζεις ότι είσαι καλός και θα είσαι καλός στο χωριό που λέμε, έτσι. Αγαπάμε το χωριό, δεν εννοώ κάτι αρνητικό, γιατί πλέον στις μέρες μας οτιδήποτε πεις θα χρησιμοποιηθεί εναντίον σου. Παρά τα αυτά, μπήκαμε στο κομμάτι των ερευνών και παίρνουμε πολλά μηνύματα, ειδικά από την ώρα που ανεβάσαμε το reel με ότι έχουμε το McGill. Είχαμε κάποιους ανθρώπους που τελικά αναρωτιέμαι αν αυτοί οι άνθρωποι ποτέ έχουν μπει στη διαδικασία να ασχοληθούν με έναν άνθρωπο που έχει πόνο. Έρχονται με φάνταστες έρευνες οι οποίες είναι μία, δηλαδή μία-δύο paper θα σου στείλουν και σου λένε με αυτή την έρευνα γίνεται αυτό, και συνήθως διαβάζουν το conclusion, το τελείωμα, χωρίς να έχει μπει μια εντοβάθεια ανάλυση από αυτού. Και η ερώτηση σε πολλά πράγματα τα οποία όντως μου έχουν στείλει και έχω προβληματιστεί, έτσι, δεν είναι ότι τα παίρνουμε έτσι απριόρι, γιατί οτιδήποτε ερώτηση γίνεται από όλους τους ανθρώπους μαθαίνουμε. Οπότε σε βάζεις μια διαδικασία να πεις ας δώσω λίγο περισσότερη προσοχή, ας δω εν το βάθη για ποιο λόγο υπήρχε αυτή η έρευνα. Και μιλήσαμε με τον Dr. McGill για το κομμάτι των ετυχιοποιημένων κλινικών δοκιμών και κατά πόσο αυτοί έχουν ουσία, έτσι, στην πρακτική, χωρίς να γινόμαστε αφαιρετικοί. Δεν σημαίνει ότι είτε το ένα ή θα είναι το άλλο. Χρησιμοποιούμε πράγματα που υπάρχουν, αλλά δεν σημαίνει παρά τα αυτά ότι αυτό είναι και... Δηλαδή βρήκαμε αυτή την έρευνα και βρήκαμε τυχαία με τα χρυσά αυγά. Μακάρι να ήταν έτσι, δεν θα πονούσε κανείς. Έτσι. Για πάμε να δούμε τι είπε από αυτό.
You used the word controlled, and I couldn't contain that. You mentioned many times randomized controlled trials, RCTs, that they might not work for back pain. I would like you to expand on why you believe that RCTs are insufficient for studying something as complex as we can see as back pain.
Well, I've said publicly, I think we should ban RCTs for low back pain. And of course, I got blowback from that. However, here's the reason why I would say that. A randomized control trial. There are very strict preconditions that must be met before you can run a randomized control trial. Number one, a intervention must be controlled. You've got to control the dose and the nature of the intervention. The second thing is that the disease that you are investigating must be homogeneous. So here we have back pain, which is only a symptom. As we've already discussed, 100 different pathways to causation and to the nature of the changes that are causing pain. That doesn't even qualify for an RCT. So an RCT, what is it good for? Well, it's really good for investigating the efficacy of a pill. A pill has a controlled dose of a somewhat homogeneous condition. Let's say something like early onset type 2 diabetes in a certain section of the population. You know what I mean? So yeah. It's somewhat homogeneous, but
what would be a good method? A better method? You've been out there for more than 3 decades. You've done it, but as the years go by and you see more RCTs, and you say, and we all know why they're not effective, what would be a good research methodology for back pain interventions?
It has to start with a thorough assessment that will subclassify the back pain into a subcategory. So there's historical studies. I think of Julie Fritz, Tony DeLito years ago. Remember, they did studies on, they subcategorized people in this group is unstable. They have micro movements, movement triggers, etc. And this group is overly stiff. So they gave randomized now manipulative mobility type of interventions, and they gave the other one a stabilizing movement kind of, and they saw efficacy for if the person is overly stiff, take them through a mobility enhancement, and if they're over our experimental research clinic, which I created it, I ran it for a lot of years at the university, categorized every person so they formed their own, but then we had to make it a bit broader so we could follow the patterns, doing pattern recognition. If they were motion in other words, both flexion and extension movements under load triggered their pain, that would be one category. We know what we gave them to. In a 2-year follow-up, we knew if they complied, because some never complied. Some were so drug-addled they couldn't even remember coming to the university. So of those ones who complied, we know exactly what the effectiveness of our approach was. We had those who were flexion intolerant. We had those who were compression intolerant. Those are pretty difficult backs to get better. If you can't take load, even the lightest load, that's pretty difficult to dig that person out. And then there were those who, can we predict who will get better based on test scores? So we went through various tests, and the prone instability test was a really good test. If the person had a positive score, in other words, we showed they had micro movements at various levels, and other tests weren't very predictive. But in any case, I think we did a fairly thorough investigation of the patterns in an effort to make the subcategories somewhat homogeneous. But then we're left with what was the dose? Randomized controlled trial. Could we control the dose? Well, now we get into, you can give a dose of an exercise to a person and it hasn't met the threshold of minimum effective dose. It's not enough to stimulate. Or it's excessive and you cross the tipping point and now the dose hurts the person.
Yeah.
So this is a real art. It's an art and a science to know how to dose it. How many days off between the doses, or how many hours off if we're doing an interval walking program? If a person gets pain after walking 10 steps, all right, walk every half an hour. Now you've guaranteed success, and maybe in a week they can walk 10 steps. Or let's make it 20 steps. Now walk 15 steps, but only do it once per hour. Okay, now they can walk around the block 3 times a day. Then finally, I can now go for a hike with my lover, my wife, who that's what I really wanted to do. I've made it there now, thank you. So there would be a graded exposure and a whole discussion on the dose. Anyway, do you see? Boy, this is a big topic.
Ένα κομμάτι το οποίο υπήρχαν πολλές φορές και πολλές συζητήσεις με πολλούς. Γιάννη, το έχουμε συζητήσει άπειρες φορές και μπορώ να πω ότι φτάνει και στα σημεία του εκνευρισμού. Από την άποψη όταν ακούει κάποιος McGill, το πρώτο πράγμα που λέει είναι ξέρω τη μέθοδο, είναι τα Big Three. Είναι το McGill Curl-Up, είναι αυτό το Bird Dog και είναι το Side Plank, έτσι δεν είναι, σωστά, ναι. Και μου κάνει φοβερή εντύπωση ένας άνθρωπος που έχει κάνει πάνω από, μου φαίνεται, 340 έρευνες. Ναι, παιδιά, είχαμε τσακωθεί και με το φίλο τον Νίκ του Μινέλο, ο οποίος το πήρε πίσω μετά, ότι ναι, σε κάποιες έρευνες χρησιμοποιηθήκαν οστά από χείρους. Τι σημαίνει δηλαδή όλο αυτό? Έχουμε γίνει τόσο πολύ αφαιρετικοί, έχουμε χάσει νομίζω το σεβασμό μας σε πολλά πράγματα από έναν άνθρωπο, και δεν παίρνω το μέρος του. Πολλοί με έχετε κατηγορήσει ότι επειδή έχουμε συνεργαστεί, επειδή έχουμε κάνει το Back Mechanics στα ελληνικά το βιβλίο μαζί, ότι είμαι μαγγιλιακός και ότι οποιοδήποτε πει κάτι για το McGill, εγώ θα πέσω στην πυρά και όλα αυτά. Σέβομαι το ότι επειδή τον έχω δει πώς δουλεύει και έχω περάσει και αρκετές εβδομάδες στο σπίτι του και στο εργαστήριό του, είναι ένας άνθρωπος ο οποίος έχει θυσιάσει πάρα πολλά πράγματα από τη ζωή του. Για αυτή την επανάσταση ουσιαστικά στη διαχείριση του πόνου από εμβιομηχανική άποψη. Ναι, είναι 3 εμβληματικές ασκήσεις, μπορούμε να πούμε, αλλά δυστυχώς από τα βίντεο που βλέπουμε στο Instagram από πολλούς έτσι, ας τους πούμε entertainers εκεί έξω, οι οποίοι χρησιμοποιούν αυτές τις 3 ασκήσεις πάρα πολύ λάθος και βλέπουμε ότι δεν νιώθουν πιθανά τίποτε, το βλέπουν ότι πρέπει να γίνουν πάρα πολύ γρήγορα ή πρέπει να γίνουν πάνω σε μποσού ή εκείνη την ώρα πρέπει να, να πάρουν και 3 μπάλες και να αρχίσουν να κάνουν και ζογκλερικά. Οπότε λογικό είναι να χαθεί αυτή η στρατηγική και η ακρίβεια της κίνησης, η οποία θα έλεγα σε όλους αυτούς οι οποίοι μπαίνουν στη διαδικασία να γίνουν έτσι υποτιμητικοί προς όλη αυτή τη διαδικασία, να ξοδέψουν κάποια χρήματα, να πάνε να περάσουν 3-4 μέρες, να βλέπουν σε ένα class, το mastery που λέει, να δούνε πώς ουσιαστικά αυτή η στρατηγική της ακρίβειας της κίνησης διασταυρώνεται με την ψυχολογία, την αντοχή, την εξατομικευμένη προσέγγιση και πώς όλα αυτά γίνεται το κλειδί για να σπάσεις όποιους περιορισμούς έχεις σαν θεραπευτής στο κεφάλι σου. Από εκεί και πέρα προετοιμαστείτε για το τι ακολουθεί.
It is, and to be honest, isn't it aggravating that people misunderstand the McGill method? That some people think that it's only the McGill 3, just try to stiffen people up. I've been there, and I want to be like uncover the whole method. Like I always say to people, you need to go there, but isn't it aggravating, like through all those almost 4 decades of all this work and people run it down that you are a bear dog, a McGill curl, and a side plank? Or you say that people shouldn't flex, which I've never heard you saying that, or stiffen up, that's it.
Well, you mean how do I handle it personally? Or I mean, I have to say, Rocco, that from a personal perspective, and this is a commentary for people listening to a white-haired old, I am in such despair as I see particularly our younger generation wasting their lives on social media. I'm lucky in my lot in life that I know a lot of the experts in various things, and I just go straight to them and seek their wisdom that they've gained through doing the work and seeing enough people over many years that they have a pretty savvy idea of what to do. But you know, if I need to fix my truck, I'll try and find a way to do it. But again, with people, you know, go to YouTube and look up the symptom of back pain, and it's just my heart sinks. I guess my question for people who are trying to consume this is, number one, would you go and get real estate advice from someone who lived in a cardboard box in the center of your city? Because that's what you're doing. The loudest voice, the most outrageous voice sometimes, do well on social media because that's the design of the algorithm. It's really pathetic. Look and ask yourself, what are the contributions of the person who I'm asking to guide me? And if they haven't made real contributions, maybe they're a marketer and they'll use the strategies of marketing. I don't know why they're trying to sway people. Is that, I mean, personally, and as far as I go on YouTube, but as far as social media goes, my life is too valuable to spend it on a phone or a computer. If I want to talk to somebody, I phone them. And if every day that I'm not out inside and I'm stuck on a computer, that's why I retired from being a professor. My job was being dominated by the computer. I couldn't stand it. I wanted to go out and raise a little hell with my friends and have fun. My message to people, which is motivated by your question but not answering the question, stop wasting your lives and time. The older you get, you realize the less of it you have, please don't waste it. Get on with life and enjoy it, and forget about the misperceptions of people. The wise person will go and seek their evidence from a person who they detect as being credible.
We had those conversations.
Would you take your car to a person who says, "Oh, you've got a sick car"? Well, with all sick cars, we change the engine. You have to leave it there and let the person try and figure out, is it poor fuel? Is it worn tires? Is it something mechanical? Is it the computer, the brain of the car? Whatever. You get my point.
I get it because, we've been working together since 2017, and I've been reading your book. I still have your first book here in my library, the Low Back Disorders, the first edition. And what I see is, because, you've sent me people in the past when they are searching here in Greece, or they're like, "Oh, we've seen a video with you with Stuart McGill, but why are we not doing those big three?" And I'm like, excuse me, what McGill does is he's trying to teach you how to approach the individual, 11 size. It's not going to fit your shoe. From my point of view, and tell me if I'm wrong, you adopt to a more personalized approach to treating back pain. Like, I remember the interview, then you've got so many tools in the toolbox, and we need to find how we're going to stress the body without creating more pain. And through there, as you say, playing jazz. And when people come to me saying, we're going to manage that with just the 3 exercises, it frustrates me.
Yeah. What was going through my mind as I was listening to this is not a pain perspective. Our overarching mission is to change people's lives. The people who come to us have back pain and they need their lives changing. But I think of other people who are very successful at changing lives. When I look at some of the elite coaches, so say we have an athlete who has back pain, I'm not the world's expert at getting them back into the octagon as a mixed martial artist or onto the Olympic 100-meter speed track. But I know who is. And I work with all of these people. And it's so interesting that they're not on social media. They are changing lives one after another. If I have someone who, many times they're a world-class sprinter, 100, 200-meter woman or man, there's 2 coaches in the world that, okay, I will give you the foundation to be pain-free up to a point, but I'm not going to get you to the 100-meter final in the Olympics, but I know who will. And they're a baseball player, and good. I will do my best to use the skills I have to give you a base athleticism so that you can start training baseball specific. But I'm going to send you to, Eric Cressey, who the performance director of the New York Yankees. Yeah. He's there because he's done it time after time after time. And almost every pro baseball player I send him does well. With hockey, if they are in Europe, I send them to Ogren and Anders Ogren in Sweden. Anders has about 45 active players in the NHL right now. Not 1, not 2. Person can get lucky and get 1 athlete back, but show me someone who's done it with 40
over and over and
that
over again.
Person knows what they're doing. I also know Anders is going to use a lot of the approaches that we have converged on because of our science. But you name a sport, and I'll probably have a coach that we will work with to hone that person into that superhuman capacity once again, not through adapting, but through managing. Playing with words, I suppose. But
no, I know 100%. And to be honest, what I would like to see at some point from you, I remember reading a book from one of my favorite neuroscientists of like 150 years ago, Santiago Ramon Cajal. He wrote a book and the title was Advice for the Young Scientist. I would love to see a book like that from you, from almost 4 decades of experience, trying to dumb down big concepts of how the body functions, but also how it performs. Because, to be honest, I don't want to sound really cocky, but the easiest thing, in a way, it could be to have a person to be out of pain, but to getting that person back and performing better than before without pain, sir, that's divine.
I agree.
You've
when
done it.
You can enhance a person's performance to a level higher after they've come to you with back pain than whatever they had before. They may have already had a state or a country best performance. But when you can get them to the world's, I don't get satisfied very often. But that turns my crank a little bit, must say.
Τελευταία δεκαετία, αυτό που και από ερωτήσεις τώρα, όλες αυτές οι συζητήσεις που γίνονται είναι και από ερωτήσεις που έχετε κάνει εσείς, είτε κυρίως προσωπικές, που μας έχετε στείλει. Ο σκοπός της τελευταίας δεκαετίας είναι κάποια βιβλία τα οποία είναι από εξαίρετους, όπως ανέφερα τον Σαντιάγο Ραμόν Καχάλ. Ψάξτε τον, έχει και από πάρα πολλούς άλλους επιστήμονες, όπως και ο Χαν Σέλιε, και μπορούμε να μιλάμε εδώ για ώρες, οι οποίοι γράφουν, ας πούμε, το απόσταγμά τους μετά από 40-50 χρόνια στον χώρο της επιστήμης, και τα κυνηγάω αυτά τα βιβλία. Δύσκολο να τα βρεις, αλλά υπάρχουν πλέον κάποιες βοήθειες σε κάποιες σελίδες στο ίντερνετ που μπορείς να βρεις παλιά βιβλία. Ναι, εσείς που θέλετε τις τελευταίες έρευνες, δυστυχώς πιθανά να μην αρκεστείτε σε αυτό, όπου θέλεις να μπεις στη διαδικασία να μάθεις το απόσταγμα, και αυτό του ζήτησα στην ερώτηση, ότι θα ήθελα να δω ένα βιβλίο από έναν άνθρωπο και μετά από τον επιστήμονα, 40 χρόνια στον χώρο αυτόν, πώς θα μπορούσε να γράψει, εν πάση περιπτώσει, ένα γράμμα, έτσι, με πολλές σελίδες, ένα βιβλίο δηλαδή, για να μπορέσει ο επιστήμονας, ο νέος επιστήμονας, να έχει όλη τη βοήθεια, αλλά και από όλους αυτούς τους ανθρώπους που έχουν θυσιαστεί όλα αυτά τα χρόνια στο ερευνητικό κομμάτι και μας κάνουν τη δικιά μας τη ζωή αρκετά πιο εύκολη. Και η ερώτηση είναι, την οποία την κάνω σε πάρα πολύ κόσμο, είναι αυτό το mastery. Και Γιάννη, θυμάσαι, και η ομιλία τελευταία που έγινε και στα ΤΕΦΑ ήταν γύρω από αυτό. Το προσπαθώ με τον Γιάννη πολύ να το δούμε αυτό το κομμάτι, πώς μπορεί να γίνει, γιατί μας ρωτάτε πώς μπορούμε να γίνουμε καλοί στο κομμάτι αυτό, και σας λέμε ότι ο χρόνος που οδηγεί στην κυριαρχία, εν πάση περιπτώσει, δηλαδή σε αυτό το mastery, εξαρτάται από την ένταση της εστίασής μας. Καλώς ή κακώς ζούμε σε μια κοινωνία που είμαστε όλοι αυτό το ADHD που το έχουν κατηγοριοποιήσει τώρα, είτε θα είναι το κινητό, είτε θα είναι κάτι. Οπότε όλο αυτό ήθελα να δω, για παράδειγμα, πώς αυτός κατευθύνεται. Έλεγε ο Ρόμπερτ Γκριν, για να μπορέσει να φτάσει στο mastery, πρέπει να κατανοήσεις, λέει, τα εξής. Λέει, να κατακτήσεις έναν τομέα. Πάνω σε αυτό να αγαπήσεις το θέμα. Και μετά να αισθανθείς μια βαριά και βαθιά σύνδεση με αυτό. Πέρα από το ενδιαφέρον για το πεδίο, πρέπει και αυτό να συνορεύει με μια αίσθηση ευθύνης. Έτσι το βλέπω εγώ. Το έχουμε συζητήσει με τον Γιάννη πάρα πολλές φορές. Και εδώ ακολουθεί κατάθεση ενός ανθρώπου που είναι 4 δεκαετίες πάνω στο χώρο. Για πάμε να δούμε τι είπε.
If you remember, we came to a quote back in 2017 when you said that our mission is to help a person enhance his biological capacity, but without overpassing the threshold. And that's what it takes expertise. And that's stuck into me. And it's one of the quotes I have here hang on my clinic. And that's the mission. I know you're really busy, and this is going to be my last question, I promise, because it's boggling time, especially now. How do you navigate the line between innovation and evidence-based practice? There are a lot of critics, and as a holy man, my faith is not how other people see me, but how I see the divine power. And I know you do, because you've got so many examples, and you've been doing it, as you know, with a lot of success all these years. But Can you help me with that? And how can we help other practitioners navigate through the line between innovation and evidence-based practice?
I think what we're talking about here, Rocco, is the path to mastery. So that would be a very large concept. There are many elements to that. And the first, I think, starts with the person's person. I know you well. Study philosophy, history, science. You're very well-rounded. I know you in that you wake up in the morning and one of your goals is to go to bed a little bit smarter than when you woke up. Am I far off the mark? I know you. That's a personality trait. If you do not have that, don't kid yourself, you're not going to master anything. The path to mastery, you think of 200 years ago, you could have a fella apprentice making barrels, a cooper, and then they would spend their entire life honing the craft of making the best barrel. Well, look at the technology these days. There will be something here that I can't figure out. I have to go and ask a 14-year-old how to do it. But interestingly enough, that 14-year-old who understands that technology will be competent for about 6 months. And then that technology is going to be replaced. So it's the way of the world now that the path to mastery is a little bit different, but I'm not backing off that idea. You've got to have the innate personality trait of being curious and committed to becoming a master and work every day to go to bed a little bit smarter than when you woke up. And in our area, I've studied with master interrogators. Why? They've helped me to perform a better verbal interview with a client.
I remember that, yeah.
I need them to tell me things that they've never told another clinician before. What were the impediments causing the failures of the previous 12 clinicians? I need to understand that. I need to get that out of them. There is an attempt to expand your mastery just to get a better interview, which is all about extracting information to inform the physical assessment that you're going to do to investigate
more than meets the eye.
How
right?
the mechanics work with their whole psychosocial aspects. Study with different coaches. People will say, well, we don't deal with athletes. We only deal with the elderly. I don't need to study athletic performance. And I say, well, you'll never be a master because it's the studying of human performance at the elite level that shows you how it's done so that you can then bring it down to an elderly person who is missing the base athleticism and you don't have enough tools to address that because you don't understand fundamental footwork. You don't understand fundamental thrust lines of how to create effective force, shall we say. That's the coaching aspect. The science, you've got to study it. And I doubt you will get it from social media. In fact, I'm sure you won't. You will be actually probably polluted by that. Do you really want to listen to who yells the loudest? That would be my answer, which has some components, but it starts with that commitment to following the path to mastery and doing the little difficult things every day to challenge yourself so that you go to bed a little bit smarter. Oh, and by the way, I'm looking at you and I'm thinking, I know you're a good human, and that's my measure of a man. These sometimes people don't have the skills or whatever, but at their base, in their heart and soul, are a good human, and I value that in you. Kindness and thoughts that you've shared with me over the years and to my family.
Means a lot to me coming from you, sir. Means a lot coming from you, and I appreciate that.
That is also an essential part to all of this. And my last point in that little story is I'm still learning to be a good human.
Ithaca.
I'm not quite there yet.
Stu, if I might say, I really appreciate your time for a great chat. Time like it's memorable. And to be honest, through this conversation, you make me a better person and a better scientist, if I may say.
Likewise. Well, let's close off now. And I thank you for doing this and your commitment to your path of mastery all the way through. And can I just ask you just to stay a couple more minutes? I want to hear about your family. Thank you.
So, Stu, you've been a master, and I know you're trying to be a master every day. If you wanted to conclude, and all the people that are trying to find mastery, what would be like the path besides the massive kind of pillars that you laid before, and that dying wish of being a better person and trying to do the work, the science, and repeating that daily and being a better person? What's been firing your soul for the past 4 decades?
To you makes me think of my good friend, Dr. Clayton Skaggs, who you know of. Clay's just written a book. I might get the title wrong. It's on my bedside table for nightly reading. It's something along the lines of the power of doing what matters. And here's a doc doing a very philosophical treatise on the power of doing what matters. You know, I have wonderful conversations with Clay, and if I said to him, Clay, what's your, you know, the path of mastery for you right now? And he's so good. He doesn't say much, but when Clay says something, it matters. And he said, my mission now is to improve my soul. How all-powerful and all-encompassing is that?
That sums it all.
Mastering being a human.
There's nothing to say on that, and hopefully we can take the. It will take a lot to take on.
Isn't that mastery?
I'll cut it now.